In this video, we'll discuss about jaundice. What is jaundice? Yellow skin caused by the buildup of bilirubin in the blood. So, yellow skin caused by buildup of bilirubin in the blood. Jaundice may occur if the liver cannot efficiently process. Our liver cannot work proper means it causes jaundice. Process red blood cell as they break down. So normal range of total bilirubin 0.2 to 0.8 milligram per deciliter. Bilirubin exit into two forms. One is conjugated bilirubin and another one is unconjugated bilirubin. This conjugated bilirubin is also known as direct bilirubin. That unconjugated bilirubin is also known as indirect bilirubin. Conjugated or direct bilirubin range 0.02 to 0.2 milligram per deciliter. Unconjugated or indirect bilirubin range 0.2 to 0.6 milligram per deciliter. These are the various normal range. Now, if that level of bilirubin is exacting greater than 1 mg per deciliter, then it is called as hyperbilirubinemia. That level of bilirubin more than 1 mg per deciliter, hyperbilirubinemia. If the bilirubin range between 1 to 2 mg per deciliter, then it is called as latent jaundice. So, greater than 1 mg per deciliter name is called hyperbilirubinemia. 1 to 2, range between 1 to 2 mg per deciliter name is called latent jaundice. If the bilirubin range level greater than 2 mg per deciliter, then it get deposited in various tissue like sclera, soft tissue and skin. It will give yellowish discoloration of that skin and sclera. So more than greater than 2 mg per deciliter, bilirubin will deposit various tissues like sclera, soft tissue and skin. It gives yellow color. Because bilirubin yellowish color, so bilirubin will giving yellow color pigment, that is recording hyperbilirubinemia. There is the one test, the detection of bilirubin, that is called Van Berg test. What is the test to use to detect bilirubin level? Van Berg test. Here we are using reagent, name is called as diazo reagent. Reagent name diazo reagent. Bilirubin detection using test Van Berg test using reagent diazo reagent. In this Van Berg test, conjugated bilirubin is water soluble. It gives water soluble purple color directly, so that's why it is called as direct bilirubin. This Van Berg test having two types. One is for conjugated bilirubin. This one will giving purple color directly. So because it is water soluble, it give purple color directly. Unconjugated bilirubin, it will give purple color only after adding alcohol. So only after adding alcohol only it will give purple color. This one water directly will give water soluble one means directly will give purple color. This one after adding alcohol only will give purple color. So this one name is called as indirect bilirubin. In the presence of conjugated bilirubin and unconjugated bilirubin both in that solution, then it will give biophysics reaction. So that one solution here both will producing conjugated bilirubin also, unconjugated bilirubin also producing. After adding alcohol here, it is producing purple color. So this type of reaction name is called as biophysics reaction. Then if that normal range we know, if that bilirubin is presented in that urine, by using test we can identify. That test name is called as modified Bouchet test. So bilirubin, if that bilirubin present that urine, by using test we can identify. That test name is called as modified Bouchet test. And now hyperbilirubinemia, it can occur due to there is increased production of bilirubin occur due to various reasons. What are the reasons? There is decreased uptake of bilirubin by hepatic tissue. Second one is decreased hepatic conjugation. Then there is a decreased excretion of bilirubin into that bile. So what are the reason for hyperbilirubinemia condition? Decreased uptake of bilirubin by hepatic tissue, then decreased hepatic conjugation, then decreased excretion of bilirubin into that bile. Then this hyperbilirubinemia can be classified into two types. One is congenital hyperbilirubinemia. Second one is acquired hyperbilirubinemia. Now first we will discuss this acquired hyperbilirubinemia. This acute hyperbilirubinemia can be classified into conjugated and unconjugated. Under this conjugated, obstructive jaundice and hepatic jaundice, two types. Conjugated having two types, obstructive and hepatic. Then unconjugated having three types, hemolytic unconjugated bilirubinemia. Second one is hepatic. Third one is neonatal jaundice. So this unconjugated having three types, hemolytic, hepatic and neonatal jaundice. Hemolytic anemia have another name, pre-hepatic. Hepatic anemia have another name, hepatocellular. This obstructive jaundice have another name is called post-hepatic hyperbilirubinemia. So now discuss this neonatal jaundice. What is neonatal jaundice? There is increased hemolysis of RBC occur. Here there is increased hemolysis of RBC occur. So there is increased breakdown of RBC. That level to that increased production of bilirubin as the liver enzyme system, hepatic enzyme system. This neonate is not mature enough to handle this load. There is no proper conjugations. So this bilirubin is there in neonate, and this physiological jaundice usually appear few days of birth. For example, after 48 hours of birth, and the bilirubin is mostly unconjugated one, because liver system of this neonate is not mature enough to handle that much load of bilirubin. Now a physiological jaundice is subside 5 to 6 days of birth. If there is increased level of bilirubin is seen 20 mg per deciliter, it can cross that blood barrier. It leads to mental retardation. So 5 to 6 days of birth, increased bilirubin level seen 20 mg per deciliter, so it leads to mental retardation. increase bilirubin in newborn to give that therapy. That therapy name is called phototherapy. We are using blue color lamp here. Here we are using blue color lamp which has wavelength between 400 to 500 nanometer. And which is converted this unconjugated, which is insoluble bilirubin into water soluble bilirubin, and that bilirubin will be excreted into urine. That is the that is regarding phototherapy. So here increased bilirubin level in newborn hue therapy name is called as phototherapy. There are using blue color lamp wavelength 400 to 500. This one water soluble, insoluble to soluble. Soluble, it will converted into water, insoluble to soluble, then it is excreted in the form of urine. Now focus on acute bilirubinemia. There are three types. One is free hepatics, another one is hepatic, third one is forced hepatic. Free hepatic have another name hemolytic jaundice. Hepatic have another name hepatic cellular jaundice. Forced hepatic name is called as obstructive jaundice. So first one is hemolytic jaundice. This one hemolytic jaundice causes sickle cell anemia, then glucose 6 phosphate dehydrogenase deficiency, then incompatible blood transmission. All these conditions, there is increased amount of hemolysis is there, that leads to increased production of bilirubin. Specifically the unconjugated bilirubin, they causes increased amount of bilirubin is produced, so a liver will not able to conjugate that much load of bilirubin, so there is increased conjugated bilirubin. We knows unconjugated bilirubin is water insoluble, so there will be absent of bilirubin in that urine. So increased urobilinogen into that urine and feces. So urobilinogen increased in urine and feces. Second one is hepatocellular or hepatic jaundice. There is damage to that hepatocellular cell due to that various reasons like viral hepatitis, toxic chemicals, various chemicals like carbon tetrachloride, alcohol, and various drugs, and liver cirrhosis condition. In this condition, serum bilirubin level increase, urine bilirubin is present, urine and fecal urobilinogen level will decrease. Third one is obstructive jaundice caused by plaquage of bile duct due to the gallstone, then carcinoma head of pancreas, then carcinoma of common bile duct. In this condition, urine bilirubin level increase. Fecal urobilinogen is absent. Urine urobilinogen also absent. Urine bilirubin present with bile salt. So the bile salt presented in urine only obstructive jaundice. Only that obstructive jaundice condition only bile salt is presented in urine, and there is one test is available to detect that bile salt in urine. That test name is called as high sulfur powder test. High sulfur powder test is the specific test to identify the presence of bile salt in that urine, absence of urobilinogen in urine and feces. Next one is congenital or inherited hyperbilirubinemia. There are basically four examples of hyperbilirubinemia. First one is Seeger-Noger syndrome. Second one is Gilbert syndrome. Third one is Dubin-Johnson syndrome. Fourth one is Rodar syndrome. These are the four examples of congenital hyperlipidemia. So what are the four example? First one is Ziegler-Naegler syndrome, then Gilbert syndrome, then Tubin-Johnson syndrome, then Rotor syndrome. These are the four example of congenital hyperlipidemia. This inherited hyperlipidemia further classified into two types, conjugated and unconjugated inherited hyperlipidemia. Conjugated examples are Tubin-Johnson syndrome, and Roder syndrome. In the case of unconjugated hyperbilirubinemia, examples are Seeger-Naegler syndrome and Gilbert syndrome. Now, discuss about what are the different clinical features of the Seeger-Naegler syndrome. It having two types, type 1 and type 2, and Gilbert syndrome. First one is features UTP glucuronosyl transferase activities. So this basically this Ziegler-Naegler symptoms occur due to the deficiency of enzyme that is responsible for conjugate bilirubin. That is enzyme name is called as UTP glucuronosyl transferase activity. This UTP glucuronosyl transferase activity is completely absent in Ziegler-Naegler syndrome. This one next type 2 markedly reduced in type 2, while Gilbert symptom reduced 10 to 33% of UTP. This glucuronosyl transferase activities seen in Gilbert syndrome. Second one is total bilirubin level. Here the type 1 Ziegler-Naegler syndrome more than 20 mg per deciliter, type 2 less than 20 mg per deciliter. This one, this Gilbert syndrome 4 mg per deciliter. Then third one is Gernictals. This one total serum, Gernictals, total serum. This one is the Gernictals. Common type, this one usually common, this one rare, this one absent. Next one is responsible for phenobarbital, apps not seen in type 1, decreased up to 25%. Here decreased bilirubin to normal. Last one is other liver test normal. All the three things is normal. Next we will discuss about Tubin-Johnson syndrome. It is autosomal recessive. This Tubin-Johnson syndrome defect in excretion of conjugated bilirubin from liver to the bile due to defect in ATP-dependent organic anion transport to bile. Then this bilirubin get deposited in liver and appear black and refer as black liver jaundice. So this Tubin-Johnson syndrome have another name that is called black liver jaundice, but less lethal. Last one is Rotor syndrome. It is similar to Tubin-Johnson syndrome. That only different is there is no deposition of bilirubin in liver. It is same as Tubin-Johnson syndrome, but there is staining of liver. So here no bilirubin deposition in liver. In this video we discussing jaundice, conjugated bilirubin, what are the ranges, then what are the tests we are using for reduction of bilirubin, then what are the reason it will causes hyperbilirubinemia, what are the two types, then acute hyperbilirubinemia, neonatal jaundice, prehepatic, hepatic, post-hepatic, hemolytic jaundice, hepatocellular jaundice, obstructive jaundice, then inherited. Then what are the laboratory features? Then Tubin-Jones syndrome. Last one is Rotor syndrome. Here there is absence of bilirubin in urine.